So thank you very much for having invited me. I'm really honored by that, and they asked me to talk about hemostatic agents. Many of us already know many of those agents, and they use them, some of them very commonly, and some of them more rarely. Now we will see those agents. One thing which is a major I want to skip those. We already went through those little definitions. But one thing which is very important in this is that the preoperative evaluation, knowing the story of the patient, knowing if she has any bleeding disorders, knowing if she's taking any medications which interfere with coagulation, antiplatelets agents, aspirin, whatever. We need to know all that and try to take all preventive measures in order to prevent what will happen later on. First of all, we need to know that all those hemostatic agents shouldn't be considered as the primary treatment for the surgical hemorrhage. First of all, we need to know that it is mostly the surgical techniques that should take care of the major part of the bleeding, and all those agents that I'm going to enumerate should be thought about as adjunct to our surgical management of the surgical bleeding. One second thought is that we need also, and we already mentioned it, is the DIC that comes with a major bleed. And as we were already saying, that whenever this happens, the best of the surgeons would look like a medical student or during the surgery. So it's very important to be ahead of the game and prevent the occurrence of those things. Now I try to divide all those hemostatic agents in functional groups to how they work. So basically I will first talk about topical agents, the physical agents, then the biological active agents, and then I will move to systemic agents, basically talk about tranexamic acid and the factor 7A, the recombinant factor 7. So basically let us start very fast with the physical agents. Bone wax, or the wax-based, like the bone wax, is mostly used whenever we have some bony lesions, mostly retropubic or the promontory, or we are moving some tumors or whatever, and then we scrape those bony areas, and we all know that this bleeding that's coming from that area is very difficult to hold, and this wax is exactly like a wax, like its name, and we just put it on that area, and we need to make sure that we are applying it on it and then remove what's exudant from it. So we do have, as I mentioned, two types. One is the bee wax itself, which is not resorbable, and because it is not resorbable, it can interfere sometimes with the bone healing and may cause infection in that area. The other type is a wax-like, water-soluble and resorbable, and that would give a better bone healing, and the incidence of infection is not like the previous one. And there is this bone putty, which is a granular hydroxyapatite, and it's water soluble, and then we can put on that area with a syringe, as I show it here. Basically, those are very rarely used because we do not often get those bony lesions or bleeding, but whenever it happens, I think those are the only way where we can really get hold of this type of bleeding. The matrix type, dry matrix, those are the most commonly used and easy to apply agents. It's a matrix which activates coagulation factors and facilitate the thrombus formation. That means the thrombus will form on that matrix, and which will lead to the hemostasis to be adequate. Of course, it is less efficient with heavy bleeding. Heavy bleeding would need surgical techniques in order to control it. Usually, we need to apply it with a gentle pressure using a wet sponge over the bleeding surface. And with those things, make sure that when we finish from applying it and removing our pressure, try as much as possible not to remove the agent with it, because then you will lose your coagulation effect over them. What are those? First of all, I will talk about the oxidized regenerated cellulose, which we all are familiar with. The Surgicel group, we have the Surgicel, we have the Surgisnow, we have the Fibrillar, all from this Surgicel company. It's from a plant. It's resorbable in 2 weeks, pliable sheets that can be used also with laparoscopy. And this image that I showed, like we cut those fabrics like with narrow lamels that we can push inside a laparoscopy procedures. It has a low pH, and in vitro experiments showed that it has a bactericidal effects against some gram-positive and gram-negative organisms. Just pay attention to sometimes when we are overwhelmed with bleeding, oozing, whatever, we tend to put big quantities of those elements, and it has been found that this quantity of residual Surgicel sheets there is associated with increased infection and adhesions. So put the layer as much as we need, but not exceed, so that we do not have residual fabrics there that would stay and contribute to increased infections. The dry gelatin matrix, we all know about the Gelfoam, for example. It's made from a partial hydrolysis of porcine collagen. It looks like a piece of foam. We do have also a powder like it, or small balls, but usually what we use in our surgical setting is mostly what looks like a piece of foam. It's absorbable in 6 weeks, and it has a particularity is that it absorbs big amounts of fluid, and we need to know that it also can expand. And because of this factor that it can expand, we would not use it in small, tiny areas where the expansion can compress some other organs that we do not want them to compress. it happens rarely in our pelvic areas, but in some other specialties, in some areas, they cannot use this because of this particularity of expansion of this product. Sometimes also we use it mixed with a topical thrombin solution, and that has been proven to increase the efficacy of this agent. And also, like the Surgicel, big amounts of Gelfoam, residual Gelfoam, may lead also to increased infection, granuloma, and fibrosis. The other matrix, the Avitene or the Microfibrillar collagen, it's an acid salt from bovine collagen. It's also absorbable over around 8 weeks. Most importantly is that in a patient which is heparinized, it is still effective, but patients who are thrombocytopenic seems not it seems not to be very effective in patients who have thrombocytopenia. So few studies have shown that it is more effective in controlling or making a thrombus, more effective than the Surgicel. And it's very important, we heard about using cell savers. If we are using cell savers, we shouldn't be using this microfibrillar collagen, which would which would provoke some embolism. Microporous polysaccharide spheres, Arista, this comes from potato starch, and the way it works is that it will create some, equivalent to a dehydration. It will absorb the water, and by this fact, it would concentrate coagulation factors and platelets, and this is how it will work on creating the thrombus. It would absorb in about 2 days, rarely associated with infections, and this product can be used with cell savers if that cell saver have the adequate filter to block this agent. Now, turn on to the biological active agents. We'll start to talk about the topical thrombin, and once we reach those agents, we need to know that those agents are much more expensive than the previous agents, but many studies have shown that they are more effective than the previous agents. So the thrombin, I'm talking here about the topical thrombin, but we will talk later about also a combination of the thrombin with some other agents. Now, this is only the thrombin. It's a solution reconstituted from lyophilized powder. As I said previously, can be used on a gelatin matrix like the Gelfoam, and once applied over the Gelfoam, it has been shown to be more effective as a to control bleeding. Now we do have the bovine thrombin, the pooled human thrombin, and more recently the recombinant thrombin. More and more now we are using the recombinant, and the bovine are being used less and less. The bovine, bovine and the pooled human thrombin are derived from plasma, and of course the recombinant is not. As adverse events with this thrombin, when it is bovine, the most important thing to think about is the immune coagulopathy that could be caused by the bovine thrombin, and the way it causes it, it's because there are some bovine factor V which would trigger the formation of some antibodies, and those antibodies would interfere with the patient factor V, and therefore create this immune problem. But as I say, we are shying more and more from this product, and we are using more and more the human, and now more recently the recombinant, which do not have those adverse effects. The human, obviously, there is a little chance, because it's the source is a human, where we can have some blood-borne infections. Rare, but we need to think about it. And the recombinant, which the only problem is that if a patient has an allergy to that product. The other is the fibrin sealants. The fibrin sealants are a combination of those two products. It's a combination of thrombin with fibrinogen, and in some commercial or industry products, sometimes it is mixed with an antifibrinolytic agent. And as we move more and more, those are products which are more and more expensive. So it's used as hemostatic, tissue sealant, and tissue adhesive. They stimulate the final stage of the clotting cascade, and when they are mixed together, those two products, they create an impermeable fibrin clot, which is quickly formed. So again, the thrombin counterpart could be the bovine, the human, or the recombinant. And we do like in the industry, we do have all those brands. And the fibrinogen, we could have either a recombinant fibrinogen, which is the newest under evaluation. It is still not available in the industry yet. It's still under study, but we hope that it would come recently, so it will be a recombinant. But mostly what we have in the industry is the human fibrinogen, which is mixed with the thrombin. And the other aspect of those fibrin sealants is that in the package we would have the thrombin, and we need to have an autologous fibrinogen, either from the patient's plasma. So there are some commercial kits to do that. Some of them are small kits, some of them are really big machines. And this is where we would form the fibrinogen from the patient, and the thrombin from the products, and those would be mixed together. And once mixed together, it could be used and applied in the patients. So whenever it is human, then again we have the same issue of thinking about the blood-borne infection. And if it is bovine, again the IMC and the allergic reaction. So it's almost we need to think about it with the same way as we thought about the thrombin. Yeah, those are some of the machines that we can get for those fibrin sealants, and very interesting to see this one, how it can make really a seal. Now I'll move to the systemic agents that we can use. Antifibrinolytic. First thing is the cyclocapron or the tranexamic acid use, which has gained lots of momentum. And talking about the study, CRASH 2 study, a huge randomized control study involving over 20,000 patients, multi-center, multi-country, blinded, and what was used was tranexamic acid, 1 gram intravenously within 10 minutes, followed by 1 gram perfusion over 8 hours. But in this study, this was used in patients with trauma associated with significant hemorrhage, and this is like about 10 years ago. And what was seen, what they noticed in this study, we can look at the area within the red circle, that when this was used in the first hour, the mortality from hemorrhage compared to the placebo, relative risk 0.68. So that's a tremendous decrease in mortality rate from hemorrhage. And we can see when we see when this was given after 3 hours, it was still effective, but the relative risk was higher, so the effectiveness was lower. And in their study, they noticed that if it was given beyond the 3 hours, then there was no efficacy, even a trend maybe that it made things worse. So, but very important thing in this study, although they have showed that it worked in controlling hemorrhage, but there was no difference in thrombotic events, whether DVTs, pulmonary embolisms, or myocardial infarctions. So this study was like about 2010, 2011. Actually, there have been the initial publication of the CRASH 2. The initial publication, they only calculated the mortality from hemorrhage when the tranexamic acid was given within 8 hours. And at that time, the relative risk was 0.85. So it did decrease mortality from hemorrhage, but at a lesser effect. But then they did a follow-up from that study. They took the same patient. They calculated the mortality from hemorrhage in the patients that received the tranexamic acid within the first hour, then within 3 hours, and then more than 3 hours. And this is where they found a major and significant differences. So tranexamic acid works, but it works if it is given earlier rather than later. Following that, we have the women trial, which also appeared in Lancet last year. And this was also a major randomized controlled trial, also involving about 20,000 patients, multi-center, multi-country, blinded also, placebo-controlled. And they gave the tranexamic acid, 1 gram IV, which was repeated after 24 hours if it didn't work. So what they found, again, this is the women's trial, mortality from hemorrhage. The relative risk of mortality from hemorrhage. When the tranexamic acid was given within 3 hours, it was 0.69. And the figure that we have from that trial, when it was overall, like given at any time, it was 0.81. So they concluded that tranexamic acid works. It decreases mortality from hemorrhage. But again, if it is given within 3 hours, the efficacy will be much more. But unlike the initial crash trial, they didn't mention not to give it after the 3 hours. In this one, this is mortality from hemorrhage from obstetrical reasons. So tranexamic acid works, and actually it is one of our one of the changing guidelines that we need to think about now with obstetrical or gynecological hemorrhage. The last thing, the recombinant factor 7A, we already talked a little bit about it. And how did it come to be used? Recombinant factor 7A is used and it is FDA approved for hemophiliacs, and mostly hemophiliacs who have antibodies. But there was a study that appeared, a case study, where a guy with a gunshot wound who became coagulopathic, all usual measures failed to control bleeding, and then that guy received recombinant factor 7A as a last resort, and nearly miraculous recovery, and that was the conclusion of that case report. And in fact, and that was like in 1999, and this case happened in a country not very far. Actually, this comes from Israel. So following that, people were encouraged to use recombinant factor 7A more and more in situations with hemorrhage, and mostly coagulopathic hemorrhage. And although it is not FDA approved for that, but it's being used more and more in other situations other than hemophiliacs or Glanzmann's disease. So it is produced by a transfection of the human factor 7 into cultured hamster cells. So it's a culture. Recombinant factor 7A binds to the surface of activated platelets, and this is where the coagulation starts, and it's not a tissue factor, it's only the surface of the platelets that promotes the factor 10 activation and thrombin generation. We say it's a bypassing agent because whatever deficiencies there are in the coagulation tree above the factor 10, it will bypass that because it's going to start the coagulation from that level downward. As I said, it is FDA approved for hemophilia with inhibitors and factor 7 deficiency. However, the off-label use of this recombinant factor 7A account for more than 90% of its utilization. So out of 10 prescriptions of recombinant factor 7, only one of them is FDA approved, and the 9 others are non-FDA approved, off-label. So how we use it? Life-threatening coagulopathic hemorrhage when all other means have failed. We do have concerns because of the FDA approvals, so use it only the same as last resort. Also, although the recommended dose by the manufacturer is 90 microgram per kilogram of body weight, however, because we do not have real studies about how much we need to use this factor in particular situations. When we read about it, we see people who have used it anyway between 50 and 120 micrograms per kilogram. Half-life is 2 to 3 hours, but as I noted, the more I'm advancing in my talk, the more those agents are becoming expensive, and this one would cost, one dose would cost about $5,000 for an average built person. So with this, this is the last thing that we have in our hemostatic agents. Any questions? Oh, last slide, efficacy. Yes, before that. Study with efficacy and safety of this product. Efficacy, this is a meta-analysis of randomized controlled trials, and it reduced the risk of receiving blood transfusions. Odd ratios 0.29. Safety, no significant difference in thromboembolic complications. As I said, because it doesn't work on the tissue factor, it works only on the surface of the platelets. And no complications, no difference in mortality rate. So its main difference is decreasing the amount of transfusion. And I think I finished now.
Thank you. Can we repeat the questions to the last? If the questions that